Welcome. In this explainer, we're going to do something a little different. We're going to step right into a simulated surgical viva, an oral exam. I'll be playing both the examiner and the ideal candidate, showing you how to really nail the structured thinking you need to manage a tough surgical case from the moment they hit the door to the long-term follow-up.
All right, candidate, have a seat. Let's get started. We're going to begin with a pretty common scenario from the emergency department. So, listen up.
And that's it. That's all you get. They keep it short and sweet on purpose, It's designed to test your immediate reaction when the pressure's on. You've got severe pain, a sudden onset, and the clock is officially ticking.
Now, this is your classic opening question. And it's a bit of a trick, isn't it? It's not asking for a fancy diagnosis right off the bat. It's testing your fundamentals. How do you handle an acutely sick patient? Your absolute first priority has to be safety and structure.
Okay, so I'm switching hats now. I'm the candidate. The only way to tackle this is to be calm, systematic, and completely focused on safety. My very first words need to show that I'm prioritizing the patient's immediate stability, not jumping into some diagnostic puzzle.
So my answer would sound something like this. Thank you. My immediate approach would be to assess the patient's airway, breathing, circulation, disability, and exposure, while starting resuscitation at the same time. That means getting 2 large bore IV lands in, drawing bloods, giving oxygen, and providing some decent pain relief. Only after I'm sure the patient is stable will I move on to getting a focused history and doing a full physical examination. See that? Safety first, always.
Now, let's talk about that focused history. Each of these questions is a breadcrumb. Was the pain sudden, like a thunderclap? That just screams perforation. Does he smoke or take a lot of NSAIDs? Huge red flags for peptic ulcer disease. You're not just asking questions, you're actively hunting for clues.
And of course, the next step is the physical exam. The vitals tell you just how sick this guy is. A high heart rate, a fever, you're thinking sepsis. But the real money is in the abdominal exam. If you feel generalized tenderness, guarding, and a board-like rigid abdomen, you've got yourself a surgical abdomen. This patient has peritonitis, and you need to figure out why, and fast. A silent abdomen with no bowel sounds, that's another major alarm bell.
Okay, examiner hat back on. Right, candidate, you've assessed the patient, you've examined him, you found peritonitis.
So, based on this whole clinical picture, what are you thinking? What conditions are on your list? This is where you have to pull all that information together and come up with a logical list of possibilities.
So as the candidate, my number one suspicion, given the sudden onset and rigid abdomen, is a perforated peptic ulcer. But a great answer never just gives one option. Acute pancreatitis can look a lot like this, though the pain often radiates to the back. And you absolutely cannot forget medical causes, like a heart attack. An inferior MI can show up as stomach pain. A quick ECG could literally save a life.
Excellent. You think it's a perforated ulcer. How are you going to prove it? This is where we go from thinking to doing. What specific tests are you ordering right now?
So, you have to be smart with your tests. Of course, you need bloods for a baseline and to check the amylase or lipase to rule out pancreatitis. The ECG, like we said, is to rule out a cardiac cause. But the absolute game changer here, the most important test, is an erect chest X-ray. You are hunting for that little sliver of free air under the diaphragm. That's the classic sign of a perforated viscus, a hole somewhere in the gut.
All right, so you've nailed the diagnosis. But you're not done yet. Now the Viva is going to test if you know how to manage this surgical emergency from here on out. And there you have it. The examiner gives you the confirmation, there's free air, diagnosis is made, the question has totally changed. It's no longer what is it, but what are you going to do about it? You need a plan for before, during, and after surgery.
So my immediate management is all about getting the patient ready for the operating room. And that's more than just making a phone call. We've got to optimize him. That means continuing aggressive IV fluids to fight the sepsis, starting broad-spectrum IV antibiotics to cover gut bacteria, putting in an NG tube to empty the stomach, and a urinary catheter to keep a close eye on his fluid status. And critically, you have to get informed consent for an emergency laparotomy, explaining all the risks and benefits. Now the examiner transports you right into the OR. You've done the laparotomy, and this is what you see. A small hole on the front surface of the first part of the duodenum. There's bile staining and contamination all over the upper abdomen.
It's a very direct, very pointed question. What is the name of the operation you're going to do?
The textbook answer and the right answer is an omental patch repair.
also called a Graham patch. You basically take a piece of the omentum, that fatty apron inside the abdomen, and you suture it right over the hole to plug it up. After that, you do a thorough peritoneal lavage, which is just a fancy way of saying you wash out the entire abdominal cavity with liters of warm saline to get all that contamination out. That is the standard of care.
But look, a good Viva never stops with a successful clean operation. The real test of a consultant-level surgeon is how they manage complications. So now, the examiner is going to really turn up the heat.
So just look at this timeline. This is a classic exam nightmare unfolding. Day 4, the patient gets septic again. The CT scan on day 5 confirms your worst fear. The repair has leaked. You try to manage it without another operation, with a drain, but it fails. The patient is now critically ill.
And here it is, the disaster scenario. You are back in the operating room, the patch has fallen apart, the tissue is swollen and inflamed and won't hold a stitch, and the patient's blood pressure is circling the drain. This is a life-or-death situation. What do you do now? Trying some complex, heroic reconstruction here is not only going to fail, it could kill the patient.
The answer here is not to be a hero. The answer is damage control surgery. Your #1 priority is saving the patient's life, not making the anatomy look perfect. That means you control the contamination with drains, you put off a definitive repair for another day, and, this is key, you establish a way to feed the patient. A feeding gastrostomy, like the one you see here, lets you get nutrition into the gut downstream while the inflamed duodenum gets a chance to heal. The mantra is, get in, control the source, get out, and get the patient back to the ICU.
So, let's wrap this up. What are the big takeaways from this masterclass? First, safety over everything. Always start with your ABCs. Second, structure is your best friend in a crisis. A systematic approach shows you're a safe, organized surgeon. Third, you've got to be ready for complications. They will happen. And finally, when a patient is crashing, the right answer is often the simplest one. Think damage control.
And let's end with this final thought. Because managing the acute crisis is one thing, but a true consultant thinks about the entire patient journey. How is this patient going to get nutrition long-term? What are the risks of fistulas or scarring down the road? This whole case just highlights that surgery isn't just about the operation itself, it's about the complete, long-term care of the person.